Hello, and welcome to this National Academy of Burn India podcast series. I am Dr. Pavan Kumar Dikshit. I am Associate Professor in AIMS Jodhpur in Departments of Burns and Plastic Surgery. And today we are focusing on electric burn injuries, a challenging and often devastating type of burn injury we see in our practice. As usual, we begin this episode with a presentation of a topic on electric burn injury. And I'm delighted to introduce our panelist, Dr. K. Kennan. Sir is from Thiruval Government Medical College. Sir is associate professor in Department of Plastic Surgery over there. Welcome, sir. Welcome to the podcast, sir.
Yes, sir. Good evening, sir.
So, sir, we will start with the article.
Yes, sir.
The article today we have chosen is factors associated with mortality, amputation, pneumonia, and skin graft loss among electric burn patients admitted in Philippines Tertiary Hospital Burn Center from 2013 to 2019. And this article was published in Burns Open in year 2021. The authors were Mar Aristio G. Poncio and Jose Joan V. Crush from the Department of Plastic Reconstructive Aesthetic Burn Surgery from Philippines General Hospital, Manila. Electric burn is the fourth leading cause of burns worldwide, categorized into two types depending on the voltage. Electric burn injuries below 1000 volt is considered low voltage electric burn injuries, and the injuries above 1000 volt considered at high voltage electric burn injury. One of the important features of this electric burn injury is the progressive thrombosis. So time is usually needed to fully delineate the extent of necrosis. So we have to wait for 7 to 10 days to exact line of demarcation to appear in cases of electric burn injuries. The objective of this study was to analyze factors associated with adverse outcomes among electric burn injuries such as mortality, amputation, pneumonia, and skin graft site loss among those who underwent split thickness skin grafting. This was a retrospective cohort study, and study was done to the patients who were admitted in Philippine General Hospital, Manila from January 2013 to December 2019. And the data of the electric burn patients were taken from Integrated Surgical Information System from the Department of Surgeries, and patients' charts were retrieved. And authors have taken ethical approval for the study. So authors categorized these electric burn patients into multiple groups on the basis of age into adult and pediatric, on the basis of total body surface area into minor, moderate, severe, on the basis of type of electric burn injury, whether it was high electric burn injuries or low voltage electric burn injuries. They also classified it as a work or non-work related injuries. Are this electric burn injury happened during the day or during night? They also noted the occupation of all the patients of electric burn injury, whether they were construction workers, electricians, and others. Injury, the time it took from injury to referral or admission was also recorded, and it was classified as immediate if it was less than an hour, early if it is less than 8 hours post-injury, intermediate if it is more than 8 hours, and it was considered late referral if it was more than 24 hours post-injury. Patients were also grouped in relation to their length of hospital stay, and subjects were also grouped based on the number of operations performed in these patients. Outcome assessment were measured as mortality, development of nosocomial pneumonia, skin graft loss, and amputation rate. And different variable mentioned above were classified as either dependent or independent. total 2,492 burn patients admitted during that period from 2013 to 2019, in which 16% patients were of electric burn injuries. They provided a graph showing annual distribution of these burn patients. The patients who were admitted by electric burn injury, they were in those patients, 94.6% patients were male. Most of the patients were adult. Approximately 75% injury was work-related. 68% patients were construction workers, and direct injury through metal rod touching to the electricity wire was 71.8% patients. High voltage electric burn injuries were 85%. Minor burn injury happened in 37% of patients, and severe injury happened in 40% of the patients. Most of the patient injured in daytime, and immediate reporting of the patient was happened in only 1% of the patient. Most of the patient referred to the came to the hospital between the window of 2 to 8 hours. They also categorized according to the burn area involved in the body. So head and neck was involved in approximately 48% of patients. Upper extremity was involved in approximately 90% of patients. Trunk and lower extremity was involved in more than 60% of patients. And they also reported a type of operation in the in electric burn injury patients. 45% patients received skin graft, 12% patient underwent amputation, only 6.6% patient underwent fasciotomy. More than 2 operations were performed in 41.7% of patients. Most 28.9% patients stayed in hospital for more than 1 month, while 23% of patients discharged within 7 days. They reported compartment syndrome in 6.9% of patients, mortality in 5.2% of patients, pneumonia in 4%, skin graft loss in 3%, and amputation in 12% of patients. They also did a survival analysis on these major variables. So taking amputation as outcome of interest, they reported that if patient had compartment syndrome, then there was 2.13-fold increased risk of amputation. Taking mortality as outcome of interest, they reported if the patient has compartment syndrome, then there was 84.5-fold increased risk for mortality. Graft site loss as outcome of interest, and they reported that 4 into 10 to the power 8-fold increase in graft site loss for patient whose trunk was affected. As there was 0.42-fold increased risk of pneumonia for every day of delay for the time of injury to the admission. So coming to this discussion, at this point, I want to ask this, sir, what are your thoughts about the study which is being performed here?
There's a good study which involves a study of about nearly 2,400 cases. Among them, electrical burn injuries corresponds to about 408 cases. It's a large number of cases only. So the study is more involved more number of cases, so they're more reliable only. Next, sir.
Yes, sir. So they reported that they had work-related activity was responsible for the majority of these high injuries.
Mainly men who are working, any member of the family, they go for work, and they, in cases, particularly construction workers, next the electricians, when they lack some that is concentration, they get the injury. 74.8% of the cases in this study, the work-related occupational becomes an occupational hazard in such cases, that electrical burns.
So is there any difference, or it is in like the same parameter in our country as well?
Yes, sir. In India also, main cause for electrical burns is work related. About 70% of cases work related only. Only few cases comes to domestic causes, which include both adult and pediatric age group, both females and male. But work related electrical burn injuries mainly men. In our study also, it is majority of men only. More than 75% of, nearly 90% of the population becomes men only, sir.
Yes, sir. Yes, sir. So, sir, taking the discussion ahead. So, just for our younger colleagues, what is the difference between the low and high voltage electric burn injuries?
Yes, sir. When the voltage is less than 1000, it becomes low voltage injuries. Here we can see what type of injuries it means. Uh, Prolonged flame or heat. The part is heat, exposed to heat for a long time, and at the same time, the chance of arrhythmias and cardiac related complications are more with low voltage. And similarly, in high voltage injuries, the devastating burst like explosion like injuries will happen, which may be associated with throwing out of that person from that site. So he will have additional injuries like fractures, head injuries, and also the depth of the burn also will be severe in high voltage injuries.
Right,
Death
sir.
is more common. Yes, sir.
So, sir, is there any difference in flash versus flame burns? Because it is
Yes, sir.
related to electric burn
Flash
injury.
burns. Flash burns is sudden exposure to a short duration exposure of a higher heat.
Okay, sir.
Within a fraction of second, the person is exposed. And for example, in case of an explosive electrical injuries, the heat will be more, but the exposure duration is in very fraction of a second. Here, many cases they present with superficial burns, and this heals faster also. But
Okay.
in flame burns, it's a long period of contact of a heated object or direct flames coming in contact with a long time. It produces deep injuries.
Yes, sir. Yes, sir. So, electric injuries often look deceptively small at entry and exit point. So, how do
Yes,
we
sir.
assess the true depth and extent of injury?
Yes, sir. Really, it's a challenging job as the main pathogenesis becomes progressive thrombosis and endothelial injury. Day by day, the severity of that electrical injury becomes worse. Many times, it becomes visible to clear the that is line of demarcation takes place in a period of 1 week to 2 weeks. In many cases, it will take even more than 2 weeks also. So to prevent the further damage, we may add on to enoxaparin and other anti-thrombotic measures we can take. So it is very difficult to initially assess the high voltage injuries, electrical burns. Sometimes low voltage, flame burns. Sometimes it may be a clear cut, small area injuries which may not further progress. In such cases, it will be easier to decide the depth of injury, sir.
Yes, sir. Going ahead, what are the systemic complications we must always be alert to related to cardiac, renal, or neurological
Yes, sir.
issues?
First 6 hours, we should take care of the heart. Many times, patient may develop arrhythmias. Patient who develops ventricular fibrillation may not even sometimes reach the hospital. This may end up in death many times. For those we receive the hospital, the electrical burn is secondary to only the cardiac management. we have to get the opinion of physicians, cardiologists, and we should address the arrhythmias first. Once it is stabilized, we will further proceed with the necessary treatment of the electrical burns. Other systemic complications, when the electrical circuit that is goes through the muscles, they lead on to deep injuries, which lead on to rhabdomyolysis, release of myoglobin, which will affect the renal system, which will produce acute renal failure, and also acute lung injury in such cases, which may affect the lung also.
Yes, sir. So, in practical terms, when patient arrives in emergency, what initial investigation should be sent?
So, essentially, we should take the complete blood count, LFT, RFT, blood grouping, particularly the packed cell volume, much more important. And we should gain a central venous access to provide adequate fluid. And at the same time, periodic investigation has to be done, repeated electrolytes monitoring. And we should also give importance to the X-ray chest and also any other injuries. For example, any fractures, suspected fractures, suspected head injuries should also be addressed accordingly. ECG will help in finding out any arrhythmia, and also if very much needed, and if any cardiac complications already established and noted, we should further proceed with the echo and all.
Yes, sir. So, what are the priorities in the first hour in electric burn injuries management, or fluid resuscitation, airways monitoring, or is there any difference in initial management from the thermal burn injuries?
So in addition to the routine management of any thermal burns, we should take care of continuous ECG monitoring and continuous fluid monitoring, and also periodical electrolyte
Yes,
management.
sir.
In addition, we have to take care of the urine output, which should be monitored correctly, and we have to give the renal. That means we should avoid acute renal failure by preventing the rhabdomyolysis. We have to give fluid in addition to the routine, so that myoglobinuria is taken care of. We should take the myoglobin, that is level in urine, and also other parameters in the
Yes, sir.
muscle indicator.
Yeah.
Yes, sir.
So another thing is that very common in electric burn injuries are development of compartment syndrome, mostly in upper limb. So what are the patterns which patients can present with in electric burn injury with suspected compartment syndrome, and how should we proceed?
Yes, sir. In many cases, when the live wire come in contact with metal rod held in the hand, the deep injuries will happen in the hand. Some cases will go for a complete charring of that limb. In such cases, the presentation of compartment syndrome will be immediate, and the charring will be present. We should act immediately. In some cases, the edema will develop in a course of time over 6 hours, 12 hours, or 24 hours. We have to constantly monitor when passive flexion of the fingers gives pain. We have to open up that compartment, that is flexor retinaculum, hand, forearm, even if required, arm also to be opened. Compartment has to be opened up, sir.
Yes, sir. There is interesting thing in which study has this reported that they had like upper limb involvement in almost 90% of patients, and they did fasciotomy in approximately only 6.6% of patients. And they also did that there was survival analysis that compartment syndrome has 46-fold increased risk for mortality.
In mortality. So
Yes.
many times, once we release the compartment, the myoglobin enters the circulation and it will produce renal failure, sir. As once we release the fasciotomy, the fluid should be in such a way that forced alkaline diuresis like that we have to do. Then only it will prevent acute kidney injury and mortality will be reduced, sir.
Yes. Coming to the management of the wound of electric burn injury, is the management is different than in the thermal burn wound?
Yes, sir. For thermal flame burns, we uh, plan escherotomy whenever there is constriction and tangential excision and other things, escherectomy and all. One of the important feature in electrical burns is once you get the demarcation early, if you see the demarcation early, we can directly go for uh, early excision and grafting, sir.
Yes, sir. Sometimes many patients present with the wound around the wrist joint, which is a very, very common presentation in these
Yes,
electric
sir.
burn injury patients, sir. So, how should we proceed in that case, sir?
We have to go for in electrical burns. Once the demarcation is established, we can directly go for a total excision of that involved portion. For example, when tendons involved and muscles involved, skin, muscle, fascia, tendon, everything has to be excised. We have to give a stable cover in the form of any local flaps or regional flaps from abdomen or any local flap from forearm. We have to give a cover temporarily, and so that we can give the healing early, and later we can go for further reconstruction.
Okay, sir. So, how do we decide between early excision versus staged procedures in which we debride and we go for a relook debridement?
Initially, once the electrical burns, once we debride, sometimes the nature of injury in such way that it again goes for darkening and it establishes itself with the gangrene. So it may need a second debridement. Once after 3 days, when there is no further discoloration, we can go for the that is permanent procedure, sir.
Okay,
We
sir.
can wait for 48 hours to 72 hours and decide further debridement is required or we can go for a cover.
Okay, sir. Sir, any thoughts about raw area cover, particularly on the upper limb in electric burn injury patients, sir?
Raw area has to be covered early, sir, with particularly like to like. We should cover because many times it's a deep devastating injuries only. So you have to give a stable cover in the form of flap, which is more worth than just grafting, sir. Only when the underlying no vital structures exposed, we will go for graft, and it's only a less number of cases, sir.
Yes, sir. Right, sir. So, again, what role does physiotherapy and rehabilitation play in long-term outcome of in these electric burn injuries?
From the day one itself, we have to keep it in mind of future contractures, future devastating deformities, and physiotherapy has to be started from the day one by frequently changing the posture and chest physiotherapy to prevent pneumonia, and that is to prevent DVT, early mobilization, even if not possible, mobilization within the bed and splinting of that all the limbs and involved joints in functional position, frequent dressing changes, encouraging the patient to go on for moving the limbs, uh, providing adequate pain relief with the help of analgesics so that they mobilize their limbs well. This can prevent future contractures and deformities.
Yes, sir. So, how are pediatric electric burns different than adults, both in presentation and treatment?
Pediatric burns, mainly the household low voltage current may be. The face and hands is commonly involved. because the child will go on playing with electrical wires, will keep it in mouth, and face and mouth is frequently involved with hands and fingers also. They, because of their surface area, uh, head and neck covers most of the body surface area. In calculation, fluid calculation, we have to give the percentage accordingly. And also, fluid during fluid resuscitation, we have to add dextrose in addition to the routine calculated fluid amount, sir. And also in minimal, that is with lesser surface area burns, the pediatric age group will recover fast and than the adult one. And
Yes, sir.
in adult, the complications, particularly as the flame burns, they are more exposed to flame burns. The prolonged contractures and other complications are more, sir.
Yes, sir. Sir, could you share your experience with long-term sequelae in these electric burning patients, more like amputation, contracture, and most importantly, the psychological effects of long-term
Yes,
sequelae
sir.
in these patients?
Yes, sir. Yes, sir. When the person is the breadwinner of that family, the family is faced with an economic crisis, and many of them, that including the patient with the attender, they go for mental depression, devastating. Even the hospital stays goes for months and months. They lost their whole of the earned money, and they go for economic crisis, which makes them psychologically very much upset. Sometimes even I have seen patients who may attempt suicide. And that also the place where they have already worked, because of amputations and all, they cannot work again. So they need support in the form of rehabilitation, occupational rehabilitation, and sometimes long-term sequelae may include cataract, neurological sequelae like paralysis, and some patients, when involved the scalp, they may go for hemiplegic, and such a prolonged, not months or even years together, they suffer, sir.
Okay, sir. Okay, sir. So, what about the social and medical legal implications, which is unique to our setting in Indian system?
Sir, in Indian, whenever we get cases, electrical or any other flame with females in a reproductive age group, and we have to ask whether the marriage is within the 7 years. We have to intimate to the police in the view of dowry. And also all electrical injuries, all burn injuries has to be reported to in MLC registration and to be intimated to the police. Only then we can save our fingers. And all cases should get the tetanus toxoid. And sometimes when patient is in deathbed, we may need to take dying declaration with the help of a magistrate. When magistrate is not available, we should take that responsibility and to record the dying declaration, sir. With other medical legal implications, sometimes they go for insurance compensation for the following amputations. They may need a new job in new places. For that, they may require support from a doctor, getting the disability certificate and all, sir.
Yes, sir. These patients suffer for a long time, and their social and psychological well-being is very important to be taken care of. So, rightly said, sir.
Yes. Yes.
So, sir, now the questions related to this has finished, but just I'd like to add one more question for these patients. Since most of these electric burn patients is work-related injuries in our setting also, So that are the workers who gets injured through this electric burn injury are can get compensation for their injury as an occupational hazard
Yes,
injury?
sir. It's an occupational hazard. When many times when the employee is a regular employee, the company takes care of them with compensation, sir. Many times when the employee is in a contract basis, they have newly appointed, and within a period of 1 month, they could not provide such a compensation. They try to avoid such a compensation for that contract employees.
Yes, sir. Yes, sir. So, sir, it's been a
What is
very
the other question?
no, sir. I think we are just nearing our time, and it has been a very productive conversation and very practical points regarding the electric burn injuries and its management. Thank you very, very much, sir, for your valuable
Thank
time.
you, sir.
And
Thank you all. Thank you very much.
yeah, and I would also like to thank the National Academy of Burn India president and the series. Thank you, everybody, for the patient listening.